So today, of course, we're going to be talking about this skull base. So we're going to pan down here so you can see that what we're going to be covering is all of the pieces of the skull base. And we're going to start with the anterior cranial fossa, move to the middle cranial fossa, and then end up in the posterior cranial fossa. So for the anterior cranial fossa, because the optic nerve, and you can see the optic nerve here in this paper clip, is very close to the anterior cranial fossa, then anterior cranial fossa meningiomas, including frontal, olfactory, planum sphenoidale, and tuberculum sellae, as well as anterior clinoid, this pointy thing, meningiomas, can all produce optic neuropathy right here. If you're a tuberculum sella meningioma or a planum meningioma, it can press on both optic nerves. This saddle-like structure is the sella turcica, and the pituitary gland lives right here. And again, because the optic nerve crosses at the chiasm, pituitary adenomas, and any suprasellar lesion produces a chiasmal field defect, usually bitemporal hemianopsia, but it can also be optic neuropathy, unilateral or bilateral, or the tract. These small foramen carry the internal carotid artery, and so that intercavernous aneurysms produce ophthalmoplegia in this location. And this oval-shaped foramen is ovale. Behind ovale is spinosum, which carries the middle meningeal artery, known most prominently for epidural hematoma after trauma across the skull base. In addition, everything from the cavernous sinus has got to travel to the orbit, and the way we get there is through this superior orbital fissure. So you can see the superior orbital fissure carries the cranial nerves from the cavernous sinus right directly into the orbit, and that's cranial nerves 3, 4, 5, subdivision 1, and 6. V3 out the foramen ovale, and V2 goes through rotundum. So we've got superior orbital fissure, rotundum, and ovale carrying divisions 1, 2, and 3 of the trigeminal. This back part here is the posterior clinoid. This is the anterior clinoid, and the posterior clinoid and the dorsum sellae are in the back part, and the superior most extension of this sloping bone is called the clivus. So the pons carries the 6th. It has to exit out the pons, and it rides right up the clivus, right up that slope, into the cavernous sinus and into the superior orbital fissure. You can notice the hypoglossal canal also is at the base of the clivus, and so cranial nerve 6 and cranial nerve 12 normally don't run together, but if they do run together, a 6 and a 12, you should really be thinking about a lower cranial nerve clival lesion. As you go to the petrous apex, that's where 7 and 8 are exiting towards your ear, and 7 is going to be exiting out the stylomastoid foramen. In the posterior fossa, this giant magnum foramen magnum, comes to us because we can have tonsillar descent through here, and that's called the Chiari Malformation. That usually presents to us as downbeat nystagmus. So you should know each of the structures of the skull base, and particularly meningiomas, which can come to us as optic neuropathies, bitemporal hemianopsias or homonymous hemianopsias, ophthalmoplegia from cranial nerves 3, 4, and 6, trigeminal dysfunction in V1, V2, V3, and just isolated 6th from the clivus, or as part of cerebellopontine angle lesions 6, 7, and 8, and a 6-12 is a lower clivus. And by the time you get to foramen magnum, we're really talking about cervical-medullary junction. That's going to be the Chiari malformation and downbeat nystagmus.